Hi, everyone. Welcome to Connecticut Orthopedics course on hypermobility and dynamic athletes. Today, myself, Scott Bloomfield, and Alicia Pascale will be going over treatment approaches for some of our more dynamic, hypermobile athletes that we will often see in the clinic. This is the 1 hour pre-course material, and this is kind of the precursor to the in-person course that we'll be having on September 7th from 5 p.m. to 7 p.m. So make sure you work through this material in full and don't hesitate to contact myself or Alicia if you have any questions before the course. That being said, let's dive in.
My name is Alicia Pascal, and I will be one of your presenters today. A little bit about myself. I am a physical therapist for Connecticut Orthopedics. I graduated from Quinnipiac University in the fantastic year that was 2020. I have worked full-time for 3 years now, and more recently, I have received my orthopedic specialty certification. In addition to this, I am currently certified for the treatment of overhead athletes through HSS, dealing with and not limited to evaluation and treatment of hypermobility in the upper extremity. Today I would like to speak about treating the hypermobile athlete with a focus on dynamic athletes to provide better, more patient-specific care. The first step to any treatment is our evaluation and assessment of the patient. What are the chief complaints? What are the problems? What are their specific goals? We need a strong history to allow them to return to their prior level of activity. Our history and physical findings are lumped into two broad categories of subjective and objective information, both collected on evaluation and should be reassessed based on plan of care, as well as when significant findings are observed, gathered, or reported in our daily treatments. What are we looking for? A patient enters our office complaining of pain in any given body part. What are the clues that might make us believe that hypermobility is at play? Patients will commonly complain of a history of subluxing or rolling of joints, buckling or giving way, a history of underactive or overactive muscle activation, such as periods of spasm, a past medical history of tendinitis, bursitis, or even reported tendon tears. Sometimes what's overlooked is that this patient may have chronic pain or pain that lasts greater than 3 months, and this pain can be constant. When asked about comorbidities, current illnesses, or medications, the patient may report history of POTS, postural orthostatic tachycardia syndrome, or GI or gut motility issues such as IBS, or flexibility of the skin with poor tissue healing. Oftentimes cardiovascular involvement can be present, as well as sleep disturbances or history of chronic or recurrent headaches. Most of the time, hypermobile injuries will not be observed on X-ray. Joint position can give you some indication, however, you cannot view tissue extensibility using this imaging device. Here's a cute picture explaining that. Thought you'd enjoy. Hypermobility is suggested from our above given subjective findings. We are then required as physical therapists to rule out more serious disorders that might require outside referral. Some of these observations are only skin deep. Get it? We look at the skin. Sorry, I know I'm not that funny. Common observations that can lead you to believe there is more systemic ailment involvement include poor quality of healing, tissue extensibility. Can they pick their skin off their body and pull it up? How long does it stay there? Evidence of piezogenic papules. I'll point these out on the next slide. Abnormal or easy bruising. Abnormal scarring. This can include hypertrophic scarring, or are there keloids present? It is also important that we observe position of joints at rest and during movement, and make note of this in the initial evaluation and how this changes throughout treatment. Have a joint mobility scaling, useful for demonstrating improvement in general joint objective findings. Also important to include on that initial evaluation. Here are some examples you may see when observing the skin and tissue quality. Pictures A and B include examples of abnormal scarring and bruising. You can also see examples of tissue extensibility. In the far right, you will see an example of the pisogenic papules, which look like hard bumps underneath the skin. These are seen more commonly in the heel. It's also good to note that these patients may present with these papules in weight bearing, whether or not they have hypermobility, and whether or not they have a connective tissue disorder. These papules are present in nearly half of the adult population. So let's get into the bread and butter of what we do. Assess general MMT of the involved joint, and also assess areas proximal and distal to the joint as seen fit by the evaluating therapist. We must observe and document balance and proprioceptive skills. Look into single leg balance, eyes closed, eyes open. Check their hopping and landing ability. Do they have good core strength? Are they lacking stability? Are there areas of hypotonia and weakness, or are some areas causing that tissue tension? It may be caused by compensation of a secondary or antagonist muscle group. Finally, if hypermobility diagnosis is suspected, we need to utilize special tests such as the Beighton Hypermobility Score. Back to Beighton's. 5 components are observed and documented. Scaling and exceptions are present in the handout we are giving you on Thursday. Out of a scale of 9 total points, above you can see the broken down categories. Passive dorsiflexion and hyperextension of the 5th MCP joint beyond 90 degrees receives 1 point for each side. Passive apposition of the thumb to the flexor aspect of the forearm, same thing, 1 point each side. Passive hyperextension of the elbow beyond 10 degrees, 1 point each side. Passive hyperextension of the knee beyond 10 degrees, 1 point each side. Active forward flexion of the trunk with the knees fully extended and the hands resting easily on the floor. This is the only category that is not observed bilaterally. It can only receive 1 point. Once you've added up the scores from the desired motions, you can determine if the patient can be diagnosed with general hypermobility. See above for the scoring based on age range. Just because the patient has hypermobility diagnosis does not mean that they have a systemic tissue disorder. However, this is a point of diagnosis for connective tissue disease, and it is an important test to utilize more frequently in the clinic and during our diagnosis to determine if hypermobility may be involved. Because systemic hypermobility may be present, I found it would be pertinent to just briefly touch upon some of the common connective tissue disorders under the category of Ehlers-Danlos syndrome and general hypermobility disorders. Stated before, Ehlers-Danlos syndrome is a connective tissue disorder that can be genetically diagnosed. There are several subtypes that can affect various body systems. The most common are classical EDS, classical-like EDS, and hypermobile EDS. Here we have 3 brief descriptions of how these categories are diagnosed and what requirements need to be met in order to make this diagnosis. I won't go into too much detail regarding this. However, if you have more questions, I will gladly refer you to the handout, which has additional inclusion and exclusion criteria. As stated in the names, these are pretty easy to remember. You have generalized, which is one or more area of the body have increased hypermobility. Localized, which is seen a lot in our clinics, is just single joint hypermobility. Peripheral means just the distal extremities, hypermobile hands, hypermobile feet. Historical is a little bit more complicated because it means one or more of the areas of hypermobility are present. However, the Beighton score is negative, but they have reported information that may have been diagnosed of hypermobility, but it happened in the past. Let's get into some of the major pathology of the lower extremity that may be caused or found in correlation with hypermobility. We will not be reviewing the upper extremity today, secondary to our course that is available solely on this treatment with the overhead athlete. I am, of course, not going to review all pathologies of the lower extremity associated with hypermobility secondary to time. Commonly seen are some non-genetic connective tissue disorders that may appear in the clinic and not be diagnosed prior to evaluation. These include benign joint hypermobility spectrum disorder and hypermobility spectrum disorder, which is typically symptomatic and categorized into 4 different types. These include generalized, localized, peripheral, and historical. Ligamentous injuries are often associated with hypermobility, including the ACL. With this being said, you can also see associated injuries such as the unhappy triad. Although some studies state this contraindicating information, hypermobility and associated abnormal landing strategies can lead to direct injury to the ligament. You may also see hyperextension injuries associated with the natural rest position of genu recavatum. That's the hyperextension, the knee is going backwards. In these patients, you will usually see a dynamic valgus with your forward step down or lateral step down testing, as well as when observing landing mechanisms, such as when you do a drop down test. Here are some resting positions to make note of and document in your observation. It can also be documented in your gait analysis or lower extremity position portion of the evaluation. It's a dynamic observation in a dancer. Here you can see the compensations noted with the lateral trunk lean, as well as the dynamic valgus. This can be and should be documented in a finding in either the other test and measures or within your special test. Here she is demonstrating the forward step-down test. Another common diagnosis of the knee that is associated with hypermobility is patellofemoral pain syndrome. You can also see patellar maltracking. This is often associated with weakness in the quadriceps femoris muscle groups and the glutes. Often seen in young women, it was found that scoliosis also had a high correlation to hypermobility and as well as patients with patellofemoral pain syndrome. You often diagnose this using the forward step down and lateral step down test. You want to look at the patellar mobility. How is it gliding? How is it tilting? What is its resting position? You can diagnose with the use of the Clark sign. And what you're really looking for is reproduction of pain during functional activities, weakness, and then that's going to be regardless of whether there's a presence of crepitus. If a patient has pain with jumping or landing, we're going to observe these techniques and note any compensatory movements. Treatment can and should follow the CPG guidelines for this diagnosis. So if dislocations make you feel a little bit weak in the knees, I would look away for this slide. Here we have an excellent example of a dislocated patella waiting to be relocated in what I can only assume is the emergency room, or only hope is the emergency room. In this patient population, you're going to see an increased risk in female versus male patients, and it's going to be higher population of young athletes. There's a variety of causes of why this happens, one being hypermobility at the ligaments. But we also have to remember that when this happens, there can be risk for further injury to additional ligaments at the knee, whether that be a sprain or a tear. It's just something to look out for. These patients might also have a history of patellar maltracking and possible patellofemoral pain syndrome. These patients might report a history of locking, grinding, and cracking, as well as additional stiffness to the knee post-dislocation, and generalized weakness. They'll have a limited tolerance to weight bearing and difficulty squatting and negotiating stairs, most often descending stairs. Not least, I would like to take this presentation down to the feet and ankles to talk about some diagnoses that can be subsequent injuries due to hypermobility. Chronic ankle instability. This is one of those diagnoses that we see pretty frequently. It's important that in these patients we discuss their history of rolling. We need to educate them on prevention and discuss chronic instability that can occur when you're continuously rolling the ankle. Over time, or even in the first event of rolling for some people, it can lead to ligament tear, tendon tear, or even fracture. In one study, there was noted to be a greater presence of sway when observed in the single leg stance position in hypermobile groups versus non-hypermobile groups. So assessment in the single leg stance position with either eyes open, eyes closed, as well as testing on uneven surfaces is important to note. Again, following the most updated CPG for this treatment. Seen in dynamic athletes and particularly dancers, there's a high population of patients with hypermobile feet. Here you can see just an example. There's some calcaneal valgus present, as well as some pes planus. There's greater flexibility in the foot, which can cause irritation to the plantar fascia and can lead to plantar fasciitis. Treatments should also follow the CPG guidelines. And when I mean that, I mean, the use of night splinting, stretching, over-the-counter orthotics. Metatarsophalangeal pain. I found this diagnosis very interesting. It's more related to dancers and when present with hypermobility and having to have positions of prolonged weight bearing on the great toe, such as in point shoes. Essentially because of the hypermobility of the ligaments in the digits, and sometimes secondary to the presence of hallux valgus, the second digit is pushed up and out. This can be ruled in and out by using the anterior draw test, if not as obvious as the picture on the right. And just a fun fact, when up in point, the average stancer can put forces up to 14 times their body weight through their feet when landing. As you can imagine, if not properly stabilized, most dancers are subsequent to ankle, foot, and toe injuries. Lastly, I'd like to speak briefly on the presence of hypermobility in the first ray of the foot. This often leads to a medial orientation of the toe and the development of hallux valgus, which is also known as a bunion. Like stated in the previous slide, this deformity can be caused by prolonged positioning as well as hypermobility and lead to metatarsalgia and abnormal positioning of the second metatarsal.
Hello there, my name is Scott Bloomfield, and I'm here to talk to you today about a topic that I'm not only passionate about, but also one that is, let's face it, pretty complicated. And the complexity of low back pain is well documented and certainly something we come across on a daily basis. Now, add in that additional variable of, say, a young athlete that's under all sorts of different types of pressures in sports that are notorious for both being repetitive and really very dynamic, and where workloads are often poorly managed. This is certainly not a recipe for prolonged success. However, having been on both sides of the coin, both as an athlete and now a clinician, I'd like to share with you some of the strategies that I use to help manage these complex cases. To understand back pain, it's important to identify the systems in play, the anatomical and physiological components, as well as the biomechanical mechanisms. Today, we'll go over these topics, which will prepare us for the evaluation and interventional components, which we will cover in person. If you are familiar with Paul Hodges and some of the work he's done with back pain, you will recognize these three subsystems he talks about: the passive, the active, and control systems. Passive, being the vertebrae, discs, and ligaments, sort of the foundation on which everything is built off of. Now, that said, this is something that I use from an educational component with patients, especially, say, a patient that's, not sold on how strengthening can be an effective mode of treating structural back pain. They looked at it, and the spine itself can hold about 90 newtons or 20 pounds of force before things start to buckle on you. Now, that is not a lot, which really gives you some perspective on how important that active system is. If you ever get a chance to look at the gross musculature around the spine with, say, the spine removed, take a look. It's impressive. It's a bit graphic, which I left it out, but it's impressive, the musculature surrounding the spine. So it's not that surprising that PT can have such a large effect on low back pain. And lastly, the control system. This is the proprioceptive component, force production, and feedback system. You can look at this system as the system that kind of ties those first two together. It's important for that feedback component from both, like I said, a proprioceptive and also a pain feedback perspective. Now, now that we know the systems that are at play, let's take a look at what movements they are controlling. For today, we've broken them down into 5 main categories to help you identify your approach and treatment plan for your patients. The 5 being extension overload, and then also flexion, rotation, compression, and/or traction intolerance. So I don't want to jump too deep into an anatomy review, but I did want to touch on some of the important anatomical considerations when it comes to identifying pain generators. Looking at the spine, you have the vertebrae, your building blocks that have those superior and inferior facets, the spinous and transverse processes, and the vertebral foramen where that nerve root comes out. It's important to keep these structures in mind when you're trying to understand the effect loading forces have through the spine, like extension forces that can go through those facets, or some flexion compression forces that goes through the disc or vertebral foramen. I have the ligaments listed there. One thing to keep in mind, these are highly innervated and can become highly sensitized with specific movements. The good news is you'll probably never have to identify which specific ligament, but you have to be able to recognize which movement is the pain generator. Briefly touching on discs, one thing that is frequently discussed with back pain is that neutral spine position. When thinking about how this affects discs, this allows the disc to most evenly distribute forces, allowing the individual to tolerate, say, maybe some higher forces with less discomfort. The annular fibrosis is highly innervated, and when these get sensitized from, say, inflammation or tearing, that's oftentimes where that pain starts to light up in the back. As we go, we'll talk about starting here in that neutral spine and how to work our way out of it so we can start moving outside of these protected positions. As I mentioned before, the spinal musculature plays a huge role. We can debate whether the core quote unquote needs to be activated. That said, there's research supports that diaphragmatic breathing is a great starting point. There are also articles that say, hey, some of this stuff is going to be involved either way. So what's important to recognize is there is a large group of different muscles controlling different motions. And as you're going through your rehab and your exercise selection, it is in your best interest to make sure that you're checking off all of these boxes. As the core as a concept requires a strong canister all the way around, and you don't want to have a weak link. Now, we've talked about all the structures that become sensitized with loading, and I'm going to start by saying I'm not trying to downplay these structures as not being important. Fractures, tears, strains, and imaging findings are all very much real and an important part of what you're going to be managing. At the same time, though, you still have a human being in front of you that you're treating. So all of those pain signs factors are in play here. And without getting into too in-depth of a pain science talk, all those psychological and psychosocial factors are going to be present at very least to a small extent in just about all the cases that you're going to be seeing. Now, this is your cue to keep your eyes open, or more so your ears open with your patients. You need to ask those questions about not just how they're feeling physically, but where are they at mentally? What is their perception of their pain? What are their thoughts on their prognosis? If you're not checking off these boxes, you might very well have an anchor attached to your interventions that is keeping you from really progressing and moving forward. If you haven't taken a pain science class or researched the best way to talk to your patients about pain, which is what we spend a good amount of our time doing, I can't recommend it enough. All of those questions that seem very, very difficult to answer become a lot easier to answer when you've taken kind of these advanced courses on pain science. My personal recommendation, find analogies on how to explain pain to your patients. Everyone has their own analogy they like to use, whether it's a house alarm or a fire alarm that's become overly sensitized, or a CEO of a big company focusing on the one singular problem. Find the one that works best for you and make it yours. So we've established what in the back can hurt and why it can hurt. Now let's dig into some of the movement patterns we'll see and their associated pathologies. First, we'll call it extension overload. Typically, we'll be seeing these with repetitive microtrauma, and I use the word microtrauma loosely. Say, for example, during a backward somersault in gymnastics, you can be seeing forces up to 14 times their body weight through the spine, and you multiply that over the course of a 4-hour practice, you're going to start seeing some of these things pop up. The first pathology that we'll start to see is facet syndrome, which is essentially the start of some of the more serious pathologies like stress reactions, stress fractures, spondies, and so on. And unfortunately, things like facet syndrome are often pushed through. Either the athlete doesn't want to stop or the coach doesn't let them. Either way, this is often the first step down the wrong path. Though these can be highly painful as the irritated facets and the surrounding structures are highly innervated and can be quite painful. So maybe this is the person in your clinic, the x-ray is good, everything on paper looks great, but they're still having that sharp pain with extension or extension with rotation and maybe some radiating pain. So they get sent over to PT because essentially everything else looks good. From there, say they didn't make any activity modifications. Well, we start down the stress reaction, stress fracture, spondy progression. This is where things start to show up a little bit more significantly on X-ray and MRI. So unfortunately, if the athlete hasn't gotten listened to this point, this is where it's maybe a little bit easier to get that activity modification, workload reduction, because, all right, well, now there's some imaging that goes along with it. Maybe now we can kind of get coaches or parents get a little more, or even the athlete to start get a little bit more buy-in that they need to kind of reduce things. In these cases, typically they're in too much pain to participate at this point, unfortunately. And in these cases, the high intensity or repetitive stress of extension or rotation and extension start to cause edema and the fracturing of that neural arch. So where the challenge becomes in this phase, all right, hey, they're not at practice. How can I keep this, athlete engaged in their practice? So even though they're not practicing, hey, you're going to get some buy-in with, hey, they can be active with PT. You're going to find some things in practice that they can participate in, which is going to start getting you buy-in from the patient, the parents, and the coaches. And one step further down the line here, spondylolisthesis, where we start to see the sliding of the vertebral bodies, which obviously big concern due to the stress that you're now putting on the neural tissue. I have the grading listed right there for your reference. Well, when we have one of these patients that arrives at our clinic, other than the referral, how are we ruling these guys in? Well, like with most tests, they're most effective when performed in a cluster. So I wanted to give you guys a cluster to look at when you have a patient and you're suspecting some sort of extension intolerance. Because as you very, very well may know, you might get a script that just says back pain on it. So we'll go over in person how to go through some of these tests. But just quickly running down the line there, we'll do a standing extension test, a stork test, so standing on one leg and extending and leaning back, stressing one side. We'll do some unloaded testing as well with a prone press up and PA shearing. Now, one test you didn't see on here, but you'll see a lot, prone instability test. Personally, I have a tough time getting these to be very specific to patients. You'll find a lot of people test positive on this one. So it's not a bad test by any means to give you some information on their core strength and the sensitivity of some of their lumbar extensors and stabilizers. So it's a good test. I'm just not sure it's ruling in everything that we'd like when we're looking at extension overload. With treatment, ideally early workload modification, which, important note, modification doesn't mean shutting down, but it does mean decreasing whatever the sensitizing activity is. During that time, you're starting on the basics of a core program, working on whichever areas you found objectively deficient during the eval. You're also working above and below as well, really building a well-rounded program. And we'll get into where to start with some of these and how to progress these quote-unquote core strengthening programs. You'll also be incorporating a global strength and conditioning program and a return to sport program to get these athletes back to their sports. As far as utilizing, say, massage or cupping or needling, none of it's contraindicated to use, and I'm certainly not against it. Some of these tools are good at reducing, sensitivity of tissues, tone, etc., which can then allow you to kind of work into some of the movements or some of the exercises that you want to. You can kind of look at your hands-on work as kind of the appetizers of your treatment, It's not the meal. It shouldn't be the meat and potatoes, so to say, of what you're doing. During the in-person course, we'll go into that kind of specific component of treatment. Next, let's flip things over and we'll discuss flexion intolerance. Oftentimes we'll see these with, say, landings that are causing, trunk flexion and compressive forces, say during a gymnastics landing or a cheerleading landing. During a landing, an athlete can be absorbing upwards of 40 times their body weight in forces, which is wild to think about. So remember from earlier, those angular walls, the end planes, all of those surrounding tissues that are so highly innervated, and either with repetitive forces or one very large force, these tissues suffer damage or can become highly sensitized. These patients typically present with axial low back pain, usually from a heavy flexion movement or twisting movement. Sometimes they'll describe a pop that they feel in their low back. There's a deep ache that may radiate into one or both glutes that worsens with sitting or bending or any sort of twisting maneuvers. You'll often see a lot of guarding and stiff posturing with these patients, as muscle spasms are pretty common. With exam, you're looking for directional preference, you're looking for dural tension, and you're doing your neuro exams as well. So here's the cluster testing for flexion intolerance, which is more or less the opposite of the extension testing that we did. I'm sure most of you are familiar with these, looking at directional preference, areas of neural tension, essentially following the low back pain treatment criteria guidelines. When it comes to treatment, the same patient and thorough approach you use with extension. Activity modification to reduce stressors. From a rehab side of things, you are starting with your symptom modulation exercises, McKenzie, reducing symptoms and getting them comfortable moving the spine again. And you're also looking above and below for areas to work on. And then once pain is controlled and mobility has returned, you can start setting forth your basic strength and conditioning program, looking to get the spine in more comfortable with loads again. Two not as common diagnoses that you'll see but are worth mentioning. Sherman's disease, where you have the rounding or wedging of the anterior portion of the vertebrae from repetitive or severely high flexion trauma. Treatments typically conservative management, PT, etc. In some severe cases, they'll use bracing. Vertebral ring apophysis happens when you have too much stress through the end plates in a younger athlete. Due to the force required for this, it typically happens with one specific moment of injury versus it being repetitive. Adverse neural tension category, this is your nerve traction injury, folks. Think about some of the extreme motions that dancers, cheerleaders, or gymnasts put their bodies in. Very large range of motion demands in some of these sports. You can certainly tug on a nerve root and have some irritation from doing this. Some of the positioning that they find themselves in are some of the positions that you check when you're looking at neural tension, say like a slump test. Some of our athletes are frequently in that position, and like I said, you can certainly tug on a nerve root there and get quite a bit of irritation. Approaching these, you'll modify workloads. You can do some neuromobs, nerve glides, tensioners to help desensitize that nerve moving in its sheath. In addition, you'll do some local strengthening above and below, then a gradual return to strength and conditioning / return to sport. Now, through this process, you're working with the athlete early to identify modifications to allow them to return to practice. I mean, yes, maybe we have some neural tension with, straight leg raise, flexion movements, but is it okay for you to say, have them practice some of their skills that kind of only have an extension component to it? Sure, why not? It is. So whether it's flexion, extension, or neural tension issue, you can still have them active in your sport, and you're going to get better buy-in from the athlete and probably the coaches as well. With rotation, typically this does not happen alone. There's usually a flexion or extension component coupled with rotation. With extension rotation injury causing a facet or spondy issue, or the reverse, a rotation flexion movement and you have a muscle strain or discogenic issue. In looking at it, you'll test side glide and standing as well as flexion. You'll test flexion rotation, extension rotation, cross straight leg raise, PA shears, stork with overpressure, We're really looking for reproduction of symptoms as well as alleviation of symptoms, which you'll find are typically opposites. And in this category, we'll have scoliosis as well. Those smaller curves, typically not a big issue, but larger ones with a large Cobb angle can be problematic. You can treat these conservatively with the Schloth method, which are exercises specifically for your scoliosis patients. If the patient is still maturing and the curve is severe, they'll use bracing or they'll do surgery. From a treatment side, what are we doing? Like the other ones, we're educating them on workload modification, allowing them to participate in activities that are pain-free and not adding to compression of the spine. When it's time to return, educate them on, say, changing surfaces. Some of these athletes, they have mats or softer landing surfaces that they could work on. You can change the type of skills that they're doing in practice to less intense variations. So it's sort of that gradual return to sport. Instead of going from 0 to 100, we need to kind of fill in those steps, and you're there to help the athlete figure out what those steps are. If we're dealing with someone that has sensitivity with compression, we're going to take a look at how that individual is supposed to buffer compression. Like for instance, say a gymnast or a cheerleader that has to buffer absorb forces when they come down during a landing. So we're going to take a look at their squat mechanics. Do they have the strength to maintain a strong squat posture? Or do they have difficulty maintaining that ideal landing or squat posture, and that's what's causing some of that compression intolerance? And like I mentioned early, loaded squats, single arm carries are a good way to start having your patient get accustomed to these higher loads and compression of the spine. Compression injuries, I really wanted to mention these today, and like rotation, you're going to see it combined with both flexion and extension forces. You're going to get a lot of sprains and strains with these. Just all those smaller muscles, tendons, ligaments between vertebrae can easily get overloaded, though you can also get end plate fractures and SI joint pain from these high compression forces as well. And the important caveat with these, especially from a treatment perspective, we now have this element of compression versus pure flexion or extension intolerance. When we're building out a program for these folks, are we properly reducing compressive forces early? How about when they're feeling better? Are we providing compressive forces as a part of their rehab to prepare them for eventually returning? If you're only doing, say, a supine core exercise program, you really haven't prepared them for any of the compressive forces. So think loaded squats, lifting, jumping, single arm carries, you name it. As far as testing for these folks, simple testing, it's a heel drop test. So you lift up onto your toes and then dropping onto the heels. You can do seated compression tests, loading anterior and posterior, looking for some of those sensitivities. And you also do some SI joint testing, Shearing's and Gazelin's tests as well. And probably the least common you'll come across is traction intolerance. And like the others, it's usually some sort of combination of reflection or extension with it. With these patients, it's a slow but progressive loading, or in this case, traction of the spine. In addition to your core work, which will be a big focus, as during those traction movements in sports, say like a gymnast on bars, the surrounding axial musculature contract and brace during these movements. Now, what does progressive traction tolerance look like? It can be as light as, say, seated at the cable column with a load pulling up, kind of like a lat pull down, but just tolerating that traction force. And then maybe progressing to a simple dead hang with one leg support, and then slowly taking some of that support away. And then eventually you'll get to the point where you progress to swing. So like I said, creativity is a big part of it, but you can certainly use those as an example of where to start. Test that you'll do with traction is a simple hanging test. If you have the capacity to do that at your clinic. Also a prone spiny test where you pull down on the legs and lift up to mimic some of those traction forces is another way that you can test for this. With this, you'll get feedback from the athlete as far as what activities are symptomatic, and that should really clue you into, okay, this is happening at, say, the bottom of the swing. That's when it's painful. I might be looking at a traction tolerance issue. Research I've grabbed here isn't related to any specific sports, but looked at the prognosis and timelines with return to sport in general. Obviously, with your own patients, you're going to find some variations with this, but this gives you kind of general timelines at which an individual will be returning and how long it takes. And you see, with most people, return to sport, which is encouraging. This is something that you can reinforce with your athletes during those kind of dark days of rehab where they're feeling like they're never going to get back. You can have a conversation with, hey, most people are going to get back to this. We just need to stick with it, follow the plans. But looking at the timelines there, obviously the more irritation, the more complexity of what's going on with the spine, those are going to take a little bit longer to heal. Now, predicting success for patients. Who does well, who struggles? Good news, some of this is in your control, while some of it might not be as much in your control. With just back pain in general, regardless of the other factors, these do better the earlier they're identified and treated using, evidence-based approaches. Unilateral and non-peripheralized issues, so patients that respond well to, say, McKenzie techniques and their symptoms centralized. Workload, fatigue, culture, communication, these are listed together for a reason. Workload in all cases is going to need to be managed. And the culture, communication with the athlete and with the coaches can be tricky. And I'll touch base with you guys on how the best way to manage that is. So now the tricky bit. If you haven't run into this as a clinician yet, you will. One of the toughest parts about managing some of these athletes that perform these highly repetitive, highly dynamic sports is sometimes it isn't the clinical component. Maybe you have the best program, you've checked off all the boxes we've discussed, but the patient isn't doing well. Well, come to find out, they're still working out because they feel pressure from their parents, from their coaches, from their teammates, etc., whatever it may be. Or maybe the coach or the parent is superseding some of the advice that you've been giving them on their own. And let's be honest, it's usually not great. So, how do we connect? How do we get everybody on the same page and cooperating? Well, the three biggest things you can do is A, have a plan, B, compromise, and C, show that you're invested. So, the first thing, establishing a plan, especially early, this can be challenging because either the coach or the parent is expecting you to predict the future, which is very tough to do. And it's important to be honest with them because if you lie, that therapeutic alliance that you're hoping to develop is out the window. I gave you some timelines to work off of. That being said, it's important to explain that there can be bumps along the way that kind of slow that time frame down. But it's good to establish an expectation. Now, explaining the plan to them, you kind of have to do your best sales pitch about what the athlete is going to be working on in PT, why it's important that we work on these things, and how the things that you're working on are going to be specific to what they have to do in their athletic setting and how it's going to get them back sooner. Now, you have to display some confidence on this. You just want to make sure that you're not arrogant, but you want to sound confident in when you're delivering this to either the athlete, the patient, or the parents or the coaches. And even if you have the best laid plan, sometimes it's still not well received. But there is one theme that came up earlier when talking about treatment, and that is workload management. Now, that doesn't mean, like I said, in most cases, completely shutting the athlete down. You still want them going to practice. You still want them engaged with the sport, but you need to establish boundaries. And that's the compromise. It's, hey, I'll get you back in the gym and, or back out on the court or whatever it is. We'll get you back out there in 2 weeks. But if you're going to do that, you have to follow some of the things that I'm recommending, or this just isn't going to work. So you've established accountability on your part, but also the athlete has established and agreed to some accountability as well. And you'll find just getting them back at practice alleviates some of that pressure that maybe the athlete would be under, whether it's from the coaches or the parents. And lastly, and don't discount how important this can be, is just showing that you're invested in the treatment. Show that you're interested in what they're doing. If you show that you're interested in learning more, you're going to get some buy-in from the patient, like, oh, the therapist is actually interested in what I do in my sport. And B, you're going to have a better idea of the moves, the tricks, the dances, whatever the athlete does, and you'll have an easier time trying to figure out what they can do in practice and what they shouldn't be doing in practice. You also get an idea of where they are from an athletic standpoint of like, all right, what other things do we need to work on? For the in-person course, there were a couple topics I wanted to touch on briefly. So I'm going to kind of graze over these concepts and we'll dive into it more on Thursday. When selecting exercise interventions, basic concepts to keep in mind. Early on, you're getting them mobile again, moving into pain-free movements, and then working into the unloaded variations to begin desensitizing those movement patterns. Once you progress through your symptom modulation exercises and pain's controlled, you're working into essentially controlled or graded exposure strategies, that progressive loading. You'll want to utilize a combination of both stabilization exercises and strengthening exercises. Meaning you can't just do stabilization work if that's what you really love, or if you really love, the heavy loading, you can't just focus on that either. So, there are a bazillion different core exercises. Which one should you do? Be creative. Remember the last slide I mentioned you should be invested in your athlete. Find out what moves they do, what skills that they were performing before they got hurt. With luck, they'll have a video which will make it a little bit easier for you, but it's going to give you a ton of information about their core control during, say, that activity, their posture during landings, all that stuff. But point being, you can analyze the movements that hurt and break them down into unloaded variations. And you can explain this to the patient as they're doing their exercises. Core exercises, let's face it, they can be a little boring. But if you make the patient feel like they're training to tolerate a specific movement in their sport, something that happens during a skill they do, they're going to be much more invested and much more engaged in completing that exercise. And lastly, the forgotten intervention, make sure you're talking to your patients to find out where they are mentally with their rehab. Try to remove this roadblock from the path. As recovery can be tough with just the physical obstacles, it'll be tough sledding if there's psychological barriers as well. And I also wanted to touch on this briefly. And it's one of those things with PT where you can have the same patient see two different therapists and the exercise flow sheet can look completely different. And in my experience, you'll see one of two things. It's either that's ultra conservative, it's weeks and weeks of pelvic tilts, abdominal bracing, because we all know how important that abdominal and core control is. Or you'll see the opposite, where maybe they're straight to the loaded squats and plyos and power production type exercises. Well, neither is really correct or wrong. Your symptom modulation exercises, McKenzie and Williams exercises, they all have their place in PT. You just can't live there. Vacation there at the beginning of the treatment if necessary, but you also have to make sure you move on to start meeting the demands of their sport. And on the other side of the coin, if you go too fast, you can end up with these frequent flares of pain where some days they're really good, then other days it's flared up because maybe you pushed a little bit too hard. Maybe they just don't seem like they're responding, or maybe they're getting stronger, but it's still painful to do the things that they want to do. So you can use all the tools in your back pain tool belt, you just can't fall in love with one of them. The next hiccup you can see in a program is only doing, say, the stabilization exercises. They're standing on one leg on a Bosu, juggling with their eyes closed. Well, stability exercises have their place. Is what you described specific to their sport? Unless Bosu juggling is their thing, it's probably not going to get them where they need to go. Or maybe you're a big strength and conditioning fan, and you just load them up and they'll be fine. You'll have some success with this, but their back pain usually feels better until they go back to that specific move or that specific skill that's giving them pain. So what you'll find is you need a well-rounded program, usually not just one or the other, and it needs to be specific to the patient. And I feel like the graphic here does a really good example of what I'm talking about. Bird dogs is a great example of a good core exercise, but if you don't progress past this and your patient wants to say do that back walk over like she's doing there in the picture, you haven't fully prepared them for it. From an intensity of the load to intensity of the speed to the compressive forces they go under. And when I was talking earlier about breaking down a skill to think about what they have to tolerate with the return to sports, this is what I mean. And you don't really have to be an expert either. So let's take a look at that back layout she's doing there on beam. Well, we know there are some extension forces there at the spine. That's probably the most obvious one. But how about the compressive forces during the landing? How about above and below? We might want to check shoulder mobility, hip mobility. Maybe that's putting more strain on the back. So even some of the moves that seem, hyper complicated, just break down what's happening biomechanically as they go through some of these movement patterns. And you look at, all right, they need to be able to extend, they need to be able to reach back with their shoulders, they need to be able to absorb compressive forces. And as you start to break those skills down, you go, your treatment plan just kind of falls right there in your lap. And this is kind of making that point that I was talking about earlier. Take a look at these two pictures. Same skills, different athletes. So even if these two showed up to your clinic with the same diagnosis, the treatment is going to be much different. One looks like, hey, she needs some mobility work, and the one on the right, hey, if she's somebody that has pain, maybe getting a good stability and strength conditioning program in place would do the trick. Going briefly into some core strength training, some core training principles. Your core training should be made up of 4 different components, and it should be specific to their sport. Focus on abdominal and neuromuscular control. It should also challenge the athlete from a stability component, and you should also progress these core loading programs with external loads if applicable. So in the early stages of rehab, you're touching on positional awareness and control of the spine. This is important to allow you to control which movements are painful and avoid those early on, and then work into them later on in the rehab process once those movements have become desensitized. Also, doing some lumbar hip dissociation exercises will come in handy when it comes time to adjust some of those more advanced core exercises, and proper positioning, say during squatting movements or deadlift movements. Just make sure you eventually do move out of these earlier core exercises. You don't get too hung up on them, on that maintaining that neutral core position, especially if you have to be able to move out of those because of their sport. So later stages of rehab, what's your core training looking like? Well, your core training should start replicating what they are trying to return to. And from an athletic viewpoint, the core, what's it doing? It's either restricting movement or it's generating force. So this is your isotrunk rotation, pull-off press type exercises where you're resisting forces, or your medicine ball tosses, or catches, trying to produce force or generate force. And in addition to that stuff, yes, you're starting to work in your strength and conditioning exercises, your squats, your deadlifts, your farmer's carries, all that good stuff. But you're also making sure they're strong in the positions that they need to perform in. So do your research on your patient's sport, ask them lots of questions. Hey, what positions are you in when you're typically having discomfort? And then you start putting together strength exercises that replicate those sporting movements. And I did want to touch on symmetry really quick. Now, symmetry between sides, most of the athletes that perform some of these dynamic sports that we've discussed, they're all very asymmetrical, and this is completely normal. So there's no real point in stressing symmetry with your athletes. You'll find they're remarkably asymmetrical people. So you don't need to go chasing a rotated pelvis, an upslip, a downslip, unless they had an injury, like say landing on one leg with great force, where you're starting to think that there might be, some sort of pain that's being generated due to, say, an alignment issue. But like I said, unless this was a patient that you're familiar with and you can test them before the injury and you knew there was no upslip or downslip, and then you test afterwards, oftentimes these asymmetrical findings that you're finding in these patients are their baseline normal. So posture is another topic that always pops up with back pain, and maybe it shouldn't, but if you do get a patient and they're complaining about their posture, like, oh, my posture is terrible, or maybe you do a postural assessment yourself and you find that they have some postural deficits, so to say. Oftentimes posture is more of a symptom of something else that's going on. Maybe there's a mobility deficit they have, or maybe a strength conditioning deficit that they have that is putting them in this posture that you're considering to be, say, correct or unhealthy, so to say. So look at it more as like a yellow flag. It's like, all right, why are they here? Is this just where they're comfortable, or is there some sort of, like I said, mobility deficit or strength deficit that they need to work on? During the in-person segment, I'll go over how to build a return to sports program. Now, these are similar to what you'll see with, say, a return to run protocol or a return to golf or a throwers program. But as you're aware, you can't really find these, say, for divers or cheerleaders or gymnasts. So I'll show you how to build a custom one to your patient. This will allow you to make that graded return to sport instead of just kind of that all or nothing. But I did want to touch on some return to sport concepts. Really, what I had mentioned before about having an open line of communication from the MD to the coaches to the parents and the athlete is really critical. Utilizing communication and having a strong set out plan from the rehab process to the return to sport process and communicating the responsibilities that each party has is going to be the key to your success to getting these patients back successfully. And I have break the boomer bust cycle, and what I mean by that is that gradual return to sport plan in place, a graded return to sport, instead of this, well, you've done pelvic tilts, you've hopefully this has been enough for you to just kind of fully return to say dancing. I'll show you how to take some of the guesswork out of it and build a home program for them to follow. That being said, thank you all for taking the time to listen today. Hopefully you've enjoyed some of the pre-course material so we can really jump into the hands-on stuff on September 7th from 5 p.m. to 7 p.m. Thank you all again for your time, and I look forward to seeing you Thursday.